So let's discuss about the vesico-ureteric reflux, which is very much important when you're discussing about the urinary tract infections in the children. Normally, the flow of the blood, the flow of the urine is obviously from the kidneys to the ureter and then to the bladder and to the urethra. But sometimes there's the opposite of that. There is a backflow of the urine from the ureter back to the kidneys, and obviously that will, in the later stages, that will lead to the chronic nephritis, and that will lead to the renal scarring. So this is a condition in which the urine flows retrograde or backward from the bladder into the ureters or back to the kidneys or the renal calyces or renal pelvis. Now, when you talk about vesico-ureteric reflux, remember there are some important anatomical and physiological structures which are responsible for a normal mechanism, which is actually the intramural length of the ureter. Then you have the diameter of the ureter, and then you have the stability or the strength of the detrusor muscle activity. So these three important constituents, they are very important to maintain a normal anterograde flow of the urine from the kidneys to the ureter, then to the bladder, and then to the urethra. But if there is abnormality anywhere in this mechanism, it's a physiological or it's an anatomical abnormality, it's because of the impaired mechanism. It's because of the short tunnel length of the ureter, which is the intramural length of the ureter, or it's the diameter of the ureter is small, or the ratio between the intramural length of the ureter and the diameter of the ureter is not appropriate. The normal ratio should be 5:1. If it's less than 4, if it's less than 3, it's the cutoff value is 3:1. So that would lead to the vesico-ureteric reflux. It's more common in the children. And almost 1 to 3% of the children, they present with the vesico-ureteric reflux. And when you talk about their gender predisposition, so it's more common in the girls, almost 3 to 5%, and 1 to 2% in the boys. But the age group is very much important. So if the age is less than 3 months, there would be more predisposition to the boys, and if the age is greater than 1 year, there would be more predisposition towards the girls. Now just have the look for this vesico-ureteric reflux. Because of this reflux, there can be urinary tract infections, there can be pyelonephritis, and ultimately this chronic pyelonephritis will lead to the renal scarring, and this renal scarring and renal parenchymal damage, because of the extensive fibrosis, will lead to the chronic kidney disease. And because of this CKD, this is the single most important cause of hypertension in the children. And obviously, because of the hypertension, there would be more effect on the kidneys, there would be decreased renal function, there would be proteinuria, and ultimately there would be end-stage renal disease. So there's a vesico-ureteric reflux, urinary tract infection, pyelonephritis, renal scarring, then there's CKD, and CKD will ultimately present with a hypertension, decreased renal function, increased creatinine levels, decreased GFR levels, proteinuria, and ultimately there will be end-stage renal disease, and obviously that will lead to the nephrectomy of the patient. Okay, so if you go back into the mechanism of vesico-ureteric reflux, you can see this is the bladder, and the ureter is entering into the bladder wall in a trigone, which is the posterior surface. This is a non-refluxing vesico-ureteric junction. So you can see it's a ureteral orifice, as not normally the orifice is closed. But in case of this vesico-ureteric reflux, first is the length of the, which is very much important, the tunnel length. So see, the tunnel length is shorter as compared to here, and that will lead to the refluxing vesico-ureteric junction. And you can see the urethral, the diameter of the orifice is very much large, and that can lead to the refluxing urethral orifice. So remember, the tunnel length diameter ratio is important when you are dealing with such patients. Then there is a grading. There are different grades for the vesico-ureteric reflux. These grades are important. We graded 1 to 5. So in grade 1, it's actually the just the minimal changes in the just ureter. There is no dilatation, but there's reflux up to the ureter. Then in grade 2, there is reflux to the ureter, and there's reflux to the renal pelvis, but without dilatation. Now, see, there's a reflux to the ureter in grade 1. In grade 2, there's reflux to the ureter and renal pelvis. And then there is a reflux to the ureter, pelvis, calcis system, and with a minimal dilatation. And then there is extensive dilatation, and the torturing, the path of the uterus torches with extensive dilatation. This is the grade 4. And in grade 5, there is extensive dilatation, and then it is accompanied by the renal scarring or renal parenchymal damage. So grade 1 is the reflux is to the ureter. In grade 2, it's ureter and renal pelvis. In grade 3, there is a minimal dilatation. In grade 4, there's a reflux with extensive dilatation, and there is tortuous ureter, and the tortuosity increases in the grade 5, accompanying with the renal parenchymal damage and scarring in the patient. If you talk about the causes, so urinary stasis, retrosis sphincter dysnergia, poor bladder emptying habit, constipation, some genitourinary complications, spina bifida, stones, outlet obstruction, and neurological disorders. These are the causes for the vesico-ureteric reflux. And when you talk about the reflux, there are primary causes and there are secondary causes. So the primary causes are related to anatomical abnormalities like detrusor sphincter dysnergia. The length of the tunnel is important, the diameter is important, and strength of the detrusor is important. The secondary causes obviously would be UTIs, stasis, constipation, neurological abnormalities, a neurogenic bladder, or there are some related to the spina bifida, and these lead to vesico-ureteric reflux. Now, management of such patients is very much important. And the first and the most important thing is to pick up this vesico-ureteric reflux very quickly. So 1 to 2% of the children with VU are asymptomatic. 40% they present with a UTI. So the first, if the patient is presenting to you with a UTI, the child is presenting to you with a UTI, you will suspect this vesico-ureteric mechanism, and you will then investigate with a specific investigation, which can be DPTA scan or which can be dimercaptosuccinic acid DMSS scanning, which actually visualizes the whole of the scarring at the kidney and the texture. So for the management, if it's a VUR, then go for the ureteric reimplantation. You can go for peri-ureteric injections of Teflon or collagen. You can also combine it with treating with the antibiotics. And the last stage, if the patient present to you is the baby is in a stage in which he has developed the end-stage renal disease, then obviously you need to treat the child with a nephrectomy. But it's important you pick up this disease earlier, because if you pick up earlier, you will treat earlier, you can reimplant the ureter, you can increase the length of the ureter tunnel, intramural ureteric tunnel, by surgical procedures, and then you can inject some Teflon or collagen to give a kind of stability and a strength to the detrusor muscle. So that's how you're going to manage the vesico-ureteric reflux in children.